Our next speaker is Roger Feldman, who is the Blue Cross Blue Shield professor of health economics at University of Minnesota. Some of you, who are not in academics and health economics may not realize this, but whenever a health economist thinks of managed care, it's synonymous with the name Roger Feldman. He has really initiated most of the research that started back before people even knew what HMOs stood for, and has done some remarkable research on that. And because that has been a very important consultant to CMS in terms of their structuring of managed care programs, and moving now on forward in all different types of structures of policies for that program. And so it's only natural that when we have a new type of healthcare model regarding financing of healthcare, that Roger Feldman would be interested in that as well. And so today he is going to talk about consumer-driven health plans and healthcare reform.
Thank you, Vivian. I really appreciate the opportunity to speak and to be part of this great panel of speakers today. The topic of my talk is consumer-driven health plans and healthcare reform. For the next 40 minutes, I'm going to tell you everything I know about consumer-driven health plans, and then we'll decide together whether these plans are just a flash in the pan or a permanent addition to the healthcare financing scene. And if it's the latter, could they become the centerpiece of healthcare financing reform? My talk breaks down into several general areas. First of all, I have to go through a little introduction. What is a consumer-driven health plan, for those who are not as familiar with the topic? Then we'll discuss who chooses a CDHP and what evidence do we have regarding their effectiveness. We'll move to ask the question, what is the potential of consumer-driven health plans to reduce the number of uninsured people, both under current law and with additional tax subsidies, and then conclude by addressing the broader question, are CDHPs really a form of better health insurance? The classic consumer-driven health plan was introduced around 2002 by a number of pioneering companies, often startups not associated with other existing health insurers. One of those was the Definity Health Plan in Minneapolis. The CDHP consisted of a high-deductible health insurance plan coupled with a tax-advantaged account that the member could use to pay for out-of-pocket medical expenses. The employer allocated money to that spending account. The member directed it. It rolled over at the end of the year, but it didn't belong to the employee, and if they switched plans or left the job, the account reverted back to the employer. Between the account and the deductible in the health insurance policy, the employee had to self-fund medical care expenditures in what was called a gap, or sometimes called a donut hole. If they did not spend the money in their reimbursement account and it accumulated, they could fund all of the annual deductible, in theory at least, off of their health reimbursement account. Preventive care was carved out and covered at 100%, so there was no cost sharing on preventive care. Expenses above the deductible were covered at 80 to 100%. So once you hit the deductible, this type of plan resembled a very generous indemnity insurance plan of the type that really predated managed care. And we'll talk about that a little bit later. Along with the health insurance plan, the enrollee was provided care management programs and internet tools to enable them to manage their health care use. In 2004, a new type of consumer-directed plan was introduced called a health savings account, or HSA. An HSA is a special account that's owned by the individual. Tax-free contributions to the account are used to pay for current and future medical expenses. The HSA is coupled with a high-deductible health plan. Now, the Bush administration has proposed refundable tax credits for individuals to purchase health plans with HSAs attached to them. So the HSA design has been offered as a centerpiece for health financing reform by the current administration. HSAs are being offered by health insurers such as United Health, the Blues, Aetna, Cigna, Humana, and Kaiser Permanente. The first question that I would like to address with evidence is who chooses a consumer-driven health plan? The strongest and most consistent conclusion is that CDHPs are preferred by highly compensated employees. In a large employer that introduced one of these plans in 2002 and also continued to offer a preferred provider organization and a point of service plan, 38% of the employees choosing the consumer-driven plan had incomes above the firm's 75th percentile. 19% of the POS and 29% of the PPO enrollees had incomes above the 75th percentile. We're trying to tease out the reasons why highly compensated employees prefer this type of health financing arrangement. One possibility is that income is correlated with other indicators of socioeconomic status, as Dana Goldman talked about in the Whitehall study. So among employees at the University of Minnesota, we controlled for both income and job classification. We classified employees as to whether they were administrators, faculty, non-faculty professionals, or civil servants. And we found that controlling for income, job class mattered, but controlling for job class, income also mattered. I believe that the highly compensated employees are willing to join this type of arrangement because they are more willing and able to self-fund the gap between their accounts and the deductible. It may also be the case that highly compensated employees are willing to try anything new, not necessarily making the correct decision. I wouldn't claim that any of the administrators at my university is capable of doing that. The next question is whether health reimbursement accounts, and I'm specifically now going to talk about the earlier version of consumer-driven plans that have a health reimbursement account that you don't own, whether this type of plan experiences favorable selection. By this we mean when it's offered as a choice, is it preferred by the people who have lower health risks? A number of commentators and policy analysts have expressed a concern that HRAs will attract healthy enrollees, thereby either destroying or lessening the degree of favorable risk pooling that occurs within an employee group insurance plan. When the University of Minnesota offered an HRA in 2002, there was no evidence of favorable selection. In the large employer that I previously mentioned, the HRA enrollees had a lower baseline illness burden than the PPO enrollees, but about equal to the POS enrollees. So there was some mild evidence of favorable selection in that case. In our largest sample of 80,000 covered lives in 3 employers, we found evidence of mild unfavorable selection against the HRA plans. Recently, we obtained data from a large aerospace firm that offers HRA, HSAs, and traditional health plans at locations all around the United States. We found that the HRA plan experienced mild, unfavorable selection, which is consistent with our previous findings, but the HSA plan had favorable selection. I'm not surprised, because healthy people have more to gain from tax-free savings accounts that they own. This suggests that offering an HSA as a choice along with other health plans might segment the risk pool into healthy and unhealthy groups. Many employers, however, are replacing all of their traditional health plans with HSAs, and in that situation, the question of adverse selection doesn't arise. The next question, and one of the most important ones, is whether CDHPs really control medical costs. The trade literature is replete with anecdotes suggesting that CDHPs will save a significant amount of money, sometimes also reducing the upward trend in medical expenses, as well as reducing the level of expenses. In response, I would say that there are very few peer-reviewed and published studies related to this question. And all I can offer you is the comment that product design is important, and it's easy to screw this up. In the large firm that we studied, the CDHP had a very generous design. There was a $1,000 health reimbursement account for single enrollees and $2,000 for families. Now, single enrollees had to self-fund $500 of expenses until they hit the deductible of $1,500. Families had to self-fund $1,000 of expenses. There was no cost sharing once the deductible was met. We found that the CDHP experienced an unfavorable cost trend that persisted after 3 years compared with the POS plan. So what we're doing in these studies is following a cohort of workers that was previously enrolled in one of the other health plans offered by the employer and who switched to the CDHP when it was offered in 2002. We're tracking their experience now for up to 3 years, seeing the effect of belonging to the consumer-driven health plan. And we found that the cost trend was definitely unfavorable. We also looked at cohorts that were classified by shorter periods of membership, and we found similar trends. When we presented this evidence to the benefit manager at the corporation, we expected him to be absolutely astounded and very negatively impressed, but we found a different reaction. He said, "Thank God it's not more expensive than my PPO." So you have to realize that the employer's goals in offering these plans may be somewhat different than those of a policymaker who's interested in their effect on cost. The benefit manager may simply want to know whether this is a viable option compared to the existing plans that were being offered. We did find that the consumer-driven health plan had a moderating effect on pharmacy cost compared with 3-tier benefits offered by both the PPO and the POS plan. Again, this isn't surprising to me because drugs are treated like any medical expenditure in the consumer-driven plan. You pay for them out of your account, then you pay for them out of your own pocket until you hit the deductible. Whereas in the 3-tiered benefit plan, the drugs are covered with typically fairly small co-payments, and also the co-payments tend to steer enrollees toward generic drugs. Now, whether or not it's a good thing to moderate pharmacy cost is another question. In other words, cost control in this area may push costs into or onto other areas. We have not answered that question with any precision at this point. Next, I'd like to talk briefly about consumer-driven health plans and the chronically ill. The appropriateness of CDHPs for people with chronic illness has been questioned, but little information exists regarding the experience of chronically ill individuals in consumer-driven plans. Along with my colleagues Steve Parente and John Christensen, we combined medical care claims with a survey of employees at the University of Minnesota. First of all, we looked at employees regardless of which health plan they were in, and we asked, how do the chronically ill differ on some interesting dimensions from the non-chronically ill? We found that employees with chronic illness are equally likely as other employees to join a CDHP. They were equally likely to understand plan coverage features, including the coverage of preventive care at 100% without any cost sharing, and to report having a particularly positive or negative experience with their plan. Next, we looked at the employees who joined the consumer-driven plan, and we compared the chronically ill within that plan to those who were not chronically ill. We found that CDHP enrollees with chronic illnesses assigned higher ratings to their plan than did other CDHP enrollees. They were more likely to use the informational tools that the plan provided, more likely to anticipate spending all of their savings account dollars, and more likely actually to have spent all of the dollars and reached the deductible. Ken Thorpe talked a lot this morning about the chronically ill and how treating them is the real challenge for health insurers. I would like to add to that and second Ken's remarks. We found that CDHP enrollees with chronic conditions who spend more than the deductible most often did so because of high drug spending. Okay. We know that a small minority of enrollees in any health plan accounts for a lot of the spending. But I think most people still are under the impression that this minority spends money because of catastrophic acute conditions like heart attacks. That's not the case. People reach the catastrophic threshold because they have chronic illness, often multiple chronic illnesses, and their spending is highly concentrated in the area of prescription drugs. In this dimension, the consumer-driven health plan, because it's like 1970s indemnity insurance, doesn't do anything to manage care. It provides free care, but not managed care. And so in this dimension, although we don't have convincing evidence, I would tend to agree with Ken that management of chronic illnesses in CDHPs will pose a challenge, and a very significant one. I'd like to talk briefly about CDHPs and prevention. As I said earlier, most of them provide 100% coverage for preventive care. HSAs may also exempt preventive care from the deductible, yet concerns have been raised that CDHP enrollees will skimp on prevention. At present, there are no peer-reviewed studies of prevention in a consumer-driven plan that combines a high deductible with a spending account. We simply don't have any evidence on pure consumer-driven health plans, but we do have some evidence about prevention in a high deductible setting. Susan Bush and her colleagues found that employees in a large firm, it was Alcoa, maintained their rates of preventive care use when cost sharing was eliminated for preventive care. At the same time, it was increased for other services. So in this employer, the company decided to tilt the cost sharing to cover prevention and cover the other services less well. And there were concerns that employees who get preventive care during a regular office visit would stop going in for office visits and therefore stop getting preventive care. But Bush and colleagues found that employees in Alcoa maintained their rates of preventive care use when cost sharing was twisted like this. Now I'd like to talk about the potential take-up of consumer-driven health plans, especially in the market for individual insurance. The Medicare Modernization Act of 2003 allows both individuals and employers to contribute to tax-free health savings accounts up to the lesser of the deductible. In $2,000, the deductible is set by law at least $1,100 for an individual and $2,200 for a family. There's a maximum contribution also set by law at $2,850 for a single person and $5,600 for a family. So between these two levels, the employee and employer may both make tax-free contributions to that spending account. The Bush administration has proposed additional subsidies for individual HSAs. In 2004, the proposal was that low-income families could receive a refundable tax credit to purchase health insurance policies with HSAs. And in 2006, the administration proposed to eliminate all taxes on out-of-pocket spending through HSAs. The premium for the policy would become tax exempt, and the cap on the contribution to the account would be lifted, so that all dollars spent on health care, whether through the premium or out-of-pocket, in an individual HSA would be tax preferred. My colleagues and I at the University of Minnesota built a microsimulation model to predict the effect of the Medicare Modernization Act and subsequent policy changes on take-up of individual insurance and insurance in the employer-offered market. Our model is broadly representative of the U.S. population between ages 19 and 64. That is, it represents adults who are not yet eligible for Medicare. We also excluded people who are on public insurance and students. And finally, not mentioned in this slide, we excluded individuals who could be covered as a dependent on somebody else's group insurance policy. We estimated a model of health insurance choice and used it to predict the plans that would be chosen by this nationally representative sample. I'll call your attention to a couple of the figures in the numbers in this presentation. We predict that the take-up of individual market health savings accounts would be roughly 3.1 million. So this is the effect of the Medicare Modernization Act of 2003, that there would be roughly 3.1 million HSA plans sold to individuals in the market where they have to go and buy insurance themselves. Despite this take-up, and despite the take-up of other types of insurance in the individual market, the majority of people who don't have access to an employer-sponsored plan would remain uninsured. You can see the number at the lowest row of the brown section of this slide, which says that 74% of the people who have to shop for insurance on their own, or 27 million people, would remain uninsured. Next, we simulated the effect of the administration's tax credit proposal. Under this plan, adults would receive a $1,000 refundable tax credit to buy an individual HSA. By a refundable tax credit, what I mean is they would actually receive the cash, irrespective of their income level, that would enable them to buy an individual HSA. So that if they were low income and they didn't pay any individual income taxes, they'd still receive the credit. There were a maximum of 2 credits per child in the family at $500 apiece. The subsidy would be phased out at higher income levels until individuals making more than $30,000 and families making more than $60,000 per year would not receive any credit. According to our prediction, this subsidy would more than double the take-up of HSAs in the individual market. There would be approximately 6.9 million of these policies sold. There would also be about 860,000 people who are offered group insurance but choose to turn it down because the subsidized individual HSA is cheaper for them. The total cost of this proposal would be roughly $8 billion per year. Since we published these results in 2005, we rethought the subsidy cost a moment, so I have to add a footnote here. You see that there is a $1.1 billion subsidy for individuals who drop their employer-sponsored policy to buy an HSA, taking advantage of the tax credit. And that would cost about $1.1 billion. On the other hand, the government would save the current subsidy that it's paying through the tax system for their employer-sponsored policies. And when we made this correction, the tax cost of the buyout of group insurance might disappear. In fact, it might even result in a slight tax saving because the group policies that are being subsidized are by and large more costly than the individual policies that people might switch to. Next, we examined the distributional impact of this policy. Couple of things to note here. The largest reduction in the uninsurance, in the number of people without insurance, is among those between 0 and 25% in the income distribution. That is among relatively low-income families. However, this is the smallest percentage reduction because that group comprises 15 million baseline uninsured people. The largest percentage impact of the subsidy is found among middle-income families, between 50 and 75% of the income distribution. These families are sensitive to the price of insurance, and they're still receiving some subsidy to purchase individual coverage. So the story here is that when we look at the distributional impacts of the Bush administration proposal, the largest reduction in uninsured is among the low-income segment, but that's the smallest percentage reduction. Why is this happening? Well, an economist would think that it might be happening because low-income people are not sensitive to these price subsidies. That is, even offering them $1,000 per individual or up to $3,000 per family might not be enough for them to buy insurance. And this is, in fact, the case. We calculated what economists call the price elasticity of uninsurance, take-up. That is, if you raised the price, how many people would drop insurance, and if you reduced it, how many people would pick up insurance. Representing this behavioral change as the ratio of two percentages, we found that the price elasticity was very small among low-income single adults and low-income families. As you go across and up the income distribution, the price elasticity increases uniformly, so that when you reach 75 to 100% in the income distribution, you find the price elasticity of insurance take-up is considerably larger. And for comparison, we calculated an overall elasticity, which is shown in the lowest row. So our results suggest that even though the subsidy for low-income people might be fairly generous, the take-up rate is going to be small unless the subsidy were even larger. Here are some policy implications and questions that I would draw from this simulation exercise. First of all, compared with medical savings accounts, which were authorized in 1996, insurers are willing to accept this, to offer this product, and buyers are ready to accept it. Most large insurers in the United States, including the Blues, now offer these policies that can be coupled with with health savings accounts. And consumers have bought them, especially in the individual market. Okay. However, to reduce the number of uninsured people, we need better targeting of the subsidy to the low-income population. The administration's proposal with phase-outs at $30,000 and $60,000 may have been a good starting point, but it wasn't generous enough at the lower end. Now I'll reflect a little bit on whether the buyout of the group market is a good or a bad thing. Personally, I don't think we need to worry so much about the buyout of the good market. The buyout of the group market. If the offered plan is an HRA, most of the people choosing it are going to be, if not in average health, possibly even in lower than average health. And the buyout, if we offer an HSA, tended to be relatively small compared with the number of newly insured people who would pick it up. There is an issue of implementation complexity. That tax credit has to be available at the time of premium payment. Otherwise, the delay could be 12 months or more, and it wouldn't be very effective. I'd like to move on into the last part of the talk, and that is whether CDHPs really are a better form of insurance. We have to start with the history of the tax subsidy for employer-sponsored insurance. The tax exemption started in World War II when wages were controlled. It was not a thought-through policy. Employers such as Henry Kaiser's shipyards needed more workers, and they found they could provide health insurance benefits without violating the wage controls. IRS rulings in the 1950s made that exemption permanent. Now, the tax subsidy for employer-sponsored insurance makes it appear cheaper to the employee, who demands more of it. I've shown a shift in what an economist would call the budget constraint, representing the trade-off between goods and insurance. Along the red budget constraint, which represents the tax-subsidized price of employer-sponsored insurance, the quantity demanded will increase. For example, let's suppose my pre-tax income is $2,000 per month, and my combined federal, state, and FICA tax is 33%, which, by the way, is representative of an average American taxpayer. I can have ESI for $500 per month. That leaves $1,500 in taxable income, so I pay $500 in taxes. If I don't purchase ESI, I'll pay $667 in tax on all $2,000 of my earnings. So buying ESI saves me $167 per month in taxes. Economists say that the price of ESI has been reduced by that tax subsidy. What's wrong with the subsidy? Well, health insurance makes health care look cheaper or even free to the consumer. The Rand health insurance experiment showed that complete insurance led to a 40% increase in spending compared with a catastrophic policy. Free care had, quote, had little or no measurable effect on health status for the average adult, unquote. Free care did lead to lower mortality for poor people with high blood pressure, but a one-time screening examination could have achieved most of that gain. In my opinion, better insurance would have some cost sharing associated with it. The real budget constraint that the population faces is not changed by insurance. So wherever we choose to locate, we have to be on that budget constraint somewhere. Free care makes us locate at a point with lots of medical care and not as many goods. If we could put in some cost sharing in the insurance policy, we would locate toward having more goods and less generous insurance. That might lead some people to advocate not having any insurance at all, but I don't want to go to that point. Health insurance protects people against the risk of a large financial loss, impoverishment, or bankruptcy. Up to a point, overconsumption of health care is a worthwhile cost of protection against risk. Will Manning and Susan Marquis estimated that a policy with somewhere between 40 to 50% co-insurance and a stop-loss limit would be ideal. The tax subsidy tilts the trade-off towards too much insurance. Now, what does the budget under a CDHP looks like? And I'm going to have to speed up here a little bit. A consumer-driven health plan has a very complicated budget and creates very complicated incentives for consumers. At first, you're spending account dollars, so you can spend more money on medical care without reducing the amount of goods you have at all. You're spending out of the account. Then you face a gap, which is just like a deductible, and finally you hit the point where insurance takes over. And I've drawn the CDHP budget as featuring 100% coverage after you get to that point. Let's sort of do a thought experiment. How would a sick consumer react to the incentives in that budget? The sick consumer would treat the account and the out-of-pocket expenses as fixed costs. They act as if medical care is free. That might not be a bad thing if the deductible is large enough, because they would have protection against some risk as well as the incentive effect of the deductible. But if the deductible is too small, it might be too easy to get to the flat part of the budget. In the employer that we studied, about a third of all contract holders got to that zone where they had free care, and not all of them had severe, chronic, or catastrophic illness that would justify free care. Here's a graph of the sick consumer. They go straight by the first two kinks on the budget constraint and get to the area where they have free care. For a healthy consumer, let's also do a thought experiment. Suppose the healthy consumer has to use the account each year or lose it. This is the case with so-called flexible spending accounts that many of us have. At the University of Minnesota, a lot of our employees have flexible spending accounts, and although we have about 7 hours of daylight per day in January, you'll see a lot of faculty members walking around with new pairs of sunglasses. They've used their tax-preferred spending account to buy these sunglasses rather than losing it. Now suppose the account rolls over but disappears if you switch plans or leave the firm. That account may have some effect on your spending. That is, you may treat that like the employer's money and not your own. And finally, suppose the account is fully portable. Here you'll treat the money as if it were your own. The incentive to save increases as you move from 1 to 2 to 3. And that's the progression as we move from flexible spending accounts to health reimbursement accounts to health savings accounts. Here's a graph of the healthy consumer with a flexible spending account encouraging you to spend all of the dollars in your account every year. And respectively, the HRA has less spending and the HSA has even less. In conclusion, as fewer restrictions are put onto the account, the incentive to save increases. But an unrestricted account looks just like a tax-preferred savings plan or a 401k plan. Now, HSAs are not completely unrestricted. You have to continue to spend them on medical care, but once you hit age 65 and you have a balance in your account, you can use the money to pay your Medicare premium. So the account becomes almost fungible with cash, and that's why I would look at it as an unrestricted account. Economist John Gruber from MIT has expressed my opinion that it's not clear why we need yet another tax savings break for rich guys. Okay. So in answer to the question that I posed originally, are HSAs or are consumer-driven health plans the centerpiece for a financial healthcare reform? My cautious answer is no. I do say yes to high deductible health plans. So if we took off the C and we replaced it with an H, a high deductible plan is a useful addition to the menu of healthcare choices. But why would anyone in an employer-sponsored situation want high deductible health insurance when the tax system penalizes them? Tax-free accounts, therefore, are a sweetener to overcome that problem. High deductible plans are much more popular in the individual market where there is no tax penalty. So if we were going to design a financial reform, and I want to be careful here that I talk financial reform to distinguish it from what other people were speaking about here today, which is health system reform, I would propose doing something to work on the tax deduction for employer-sponsored health insurance. In 1983, the Treasury Department proposed a cap on that deduction. President Bush proposed a variant of this idea in his 2007 State of the Union address. Others have argued that we should replace the tax deduction with a refundable tax credit to purchase health insurance. And finally, a possibility that hasn't been discussed much is to let all healthcare spending be tax-free. After all, when we talk about health insurance improving outcomes or health insurance improving health, what we really mean is health insurance allows you to get medical care, and medical care improves your health. So if it's medical care that we want to subsidize, why don't we do that, whether it be through insurance or out of pocket? The 2007 SOTU, or State of the Union proposals, deserve a brief discussion. President Bush has proposed replacing the current tax deduction for employer-sponsored health insurance with a flat $7,500 deduction for a single individual and $15,000 for a family. The deduction could be used to buy either employer-sponsored or individual health insurance. The administration predicts about 3 million newly insured as a result of this policy and 10-year budget neutrality because the subsidy will be indexed to the cost of living, not to medical care inflation. In the out years, the proposal would save money, but immediately it would cost money. Our microsimulation model predicts a larger insurance take-up, but also larger costs. So my advice to the administration, which I'm hoping to give on Monday at the American Enterprise Institute, is that they should be afraid of getting what they wish for. Okay. In summary, then, I hope I've told you about consumer-directed health plans. Reviewed the evidence. And there's now an accumulating body of evidence suggesting who joins them and what effects they have. I've talked about consumer-directed health plans as a form of better insurance, and I've made a cautious argument that it is not consumer direction we want, it's a high-deductible health plan, and then briefly summarized the tax treatment of health insurance, arguing that the way to level the playing field between different types and different sources of insurance is to modify the current tax deduction for ESI.
got a couple of questions for you. First, I'm embarrassed. Here I am. I'm a PhD health economist, and I'm supposed to be an expert on this. What I can't get my my sort of mind around is as a consumer, how do I figure out whether I'm going to spend more out of pocket with a CDHP versus one of the other plans, and how does that differ for whether you're healthy or you're chronically ill?
Well, it depends on the cost-sharing arrangements in your other plans. Suppose your other plan has a 20% coinsurance up to a $10,000 out-of-pocket limit. Then if you're chronically ill, you'd be much better off enrolled in a CDHP that limits your exposure at most to the gap. I have a colleague, he's a sample of one, but I find him very, very useful to talk to him. He is a high spender and belongs to a consumer-directed plan. He views the HRA as gone. He's going to spend that anyway. He views the gap as a fixed cost, and then he gets to the point where he has 100% coverage and can go down to the Mayo Clinic. Incidentally, a number of health insurers are now providing the internet-based tools to help us game the system. Those are being offered by United Health Group for one, and by a number of independents, such as a company called Subimo for another. So you can, as Dana said, Google the right answer for yourself.
Okay, the other question I have is on the Bush proposal. They do favor there's additional tax preferences for HSAs. And the Brookings Institute has come out with a paper criticizing that approach, saying, why should you give special tax preference to HSAs versus other things like managed care? And could you comment on that particular issue?
Good point, Vivian. Under the 2007 proposal, in fact, under the two previous proposals, the preference is specifically given to HSA plans. So let me speak directly to the 2007 proposal. Every health plan would be eligible for the deduction, but HSAs would still receive the tax-preferred status for the healthcare accounts. Okay. And the criticism of that strategy is that it favors one type of insurance over others. And what we're trying to do with this reform is to eliminate the preference for where you obtain your insurance and how much you obtain. So I disagree with that approach. I think the proposal should have eliminated the preference for tax-free accounts. It did eliminate another preference, which is, well, actually two. It eliminates flexible spending accounts, and it eliminates so-called Section 125 plans where I can pay my out-of-pocket premium with tax-free dollars. So in this respect, I think there's a lot of tax fairness in the policy, but in the subsidy for HSAs, I agree with you. That's a holdover, and I think it reflects the preference of some people in the administration for this particular type of insurance.
Roy Rampton, I'm a consultant in Washington, D.C. Given what we've heard from the first two speakers this morning, is it appropriate to consider insurance an appropriate financing mechanism for chronic care and all of the disease management that is needed, as well as the preventive care, which seems to be increasingly important that we get to avoid those type of mechanisms? Clearly, the risk is known once the individual has been diagnosed with a chronic condition, and there's really nothing risky about covering preventive care and a lot of wellness programs, if you would comment on that.
That's a good point. The flaw, in my opinion, of these consumer-directed plans, in their original version at least, is a lack of thought, a lack of attention to medical care delivery and care management. I think that is being addressed. A couple of examples for you. One of them is at the University of Michigan, where they have made an exemption for drugs for chronic illness. A lot of that effort is being led by an economist who is now at Harvard University named Mike Chernew. Another example, and one that I think is extremely interesting, is a consumer-directed plan that's offered by a hospital in Minneapolis. Starting next year, they're going to offer you a $50 reduction in your HSA premium if you quit smoking, and if you can demonstrate control of hypertension, and so they're combining financial incentives with care management. I think this is compatible with what the two speakers earlier this morning were talking about. Now you can combine both of those subsidies together. Now I wouldn't recommend that we start smoking and get ourselves into bad health in order to get those incentives. But if you started in that situation, you can get a free HSA by engaging in those activities.
Mark Silverstein from Methodist Hospital. I'd like to ask you about the phenomenon of concierge medicine, concierge physician practices. Clearly they can be associated with a high deductible premium, and then there are some costs that are upfront, sort of on an ongoing basis, as separate from maybe an insured component of utilization. And I'm not sure how to think about those in the context of these consumer-driven health plans.
Well, I'd encourage anyone else to respond to that. Also, you could think of concierge medical care as paying a premium to guarantee you access when you want it, as we pay premiums to get all sorts of other access, like preferred parking privileges at my university. I have no problem with that. I just don't want to include it in the insurance policy. If someone wants to cover that type of care, if they want to cover cosmetic surgery or whatever from their own income, that's fine with me.
I'm Betsy Schwartz with the Mental Health Association in Houston, and I have a question regarding mental health insurance coverage. We've worked here in Houston to get many major corporations to include equal mental health benefits, and have proven with over 200,000 covered lives what is similar to a lot of national research, that the cost for providing equal benefits is less than 1%, and the offset in lower utilization of health care and increased productivity, all the things that I'm sure you know is true. There's the Wellstone bill that now has come surfaced again, but in working with the Texas legislature, members of the leadership of the legislature have encouraged us to create a tax incentive for insurance companies to provide equal mental health benefits. And in researching this across the country, we haven't found any place that's done that. I'd like your comment on what you think of providing an insurance tax incentive subsidized by the state, and if you know of anywhere that's been tried.
I don't know of anywhere it's been tried. I'm somewhat more skeptical of creating tax subsidies for particular benefits than you are, but I think let me respond about how this is done in the HSA HRA environment. There, mental health care is on an equal footing with other services. It's equally covered. You can pay for it out of your account, then you have to pay out of pocket, and then it will be covered by the insurance policy. I can give you perhaps one insight into the effect of this type of coverage on drugs that are used to treat mental illness and mental health conditions. We compared the per capita use of those drugs in the CDHP versus in the three-tiered plans that were offered by the big employer in my study. We found no difference in the utilization. Now that may indicate to you that there's sort of global underuse, but in terms of the incentives that are contained in this type of insurance, it seems to be pretty neutral when it comes to mental health situations.
I'm Rich Johnson, head up the Texas Medical Association's Division of Medical Economics. Thank you for your presentation, by the way. It was very good. The one piece of data I was interested in that you mentioned had to do with the concern about the low take-up factor for low income, looking at the HSA possibility. What opportunities do you think are out there, given that an advanceable tax credit is not likely to be something that's politically palatable? What opportunities exist between health plans and employers to create an opportunity there to finance that?
That's a great question. I want to give you, first of all, an answer that the situation in terms of the size of the subsidies that can be delivered is not as grim as the low response or low take-up elasticities. In other words, the actual observed take-up is the product of a fairly small elasticity, and maybe we could make a bigger credit or deduction. An example would be a family earning $15,000 a year. If they're exempted from Social Security taxes, that's worth almost $2,500 to that family, regardless of how much personal income tax they pay. So that's number one. Now, number two is what employers can do to improve the situation. A number of employers are making the employees' out-of-pocket premium be related to the employee's level of income, so that lower-paid employees pay a smaller fraction of the health insurance premiums. And I think that's an excellent idea. That would encourage some low-paid employees who at present might decline their employer's offer to pick it up. And an example of that is both David Cutler and my son work for Harvard University. I think David's probably a little bit better paid than Nathaniel is, who is the assistant women's tennis coach. But as an employee in the lower compensation levels at Harvard, his monthly premium is smaller.
Regardless of what the amount of money that might come back to a poor person, $2,500, $3,000 for the family, $1,000, whatever, and I have this money to go buy health insurance, given the population we're talking about that have no experience with ever having had health insurance. One, what would the policies, what's a $3,000 family policy going to cover? I mean, I don't know where one would go buy such a thing today, but if one could, what on earth would it cover, and why would it attract them to come buy it? But the second thing is, who would sell it? I mean, what's the incentive to agents? And also, you're dealing with a population that perhaps the only insurance agent they've ever met is someone that they bought their automobile insurance from. They certainly wouldn't have the foggiest idea how to go find an insurance agent that sells health insurance. So the other question is, how would these things be sold? And I mean, are insurance agents actually lining up wanting to sell these things?
Let me address that two-part question in reverse. I think both large insurance companies like United and smaller insurance companies are very willing to sell these policies. In the case of United Health Group, we had the gentleman here who spoke for them earlier. They first bought Golden Rule of Indianapolis, which had sold individual HSAs for many years without the tax privilege, to give them some experience in how to deal with this product. And then they bought Definity in 2005, and now they're one of the major offerers of HSAs to both the individual and the group market. Now, you and I as individuals can go to a website called ehealthinsurance.com, punch in our zip code, our age, whether or not we smoke, and so on, and get quotes from numerous insurers regarding the individual policies that they'll sell us, many of them being compatible with health savings accounts. I think the first part of your question is a very serious, could relate to a very serious problem, which is what kind of insurance can you really buy with the $3,000? And then even after you buy it, will that newly insured person who's never had health insurance before in their life make use of the insurance benefits and understand the policy design and so on? The kind of problems that Dana talked about earlier, I think still would persist. In response, a person who supports this whole notion would tell you that the take-up of these plans has been 3 million so far, and it's actually now closer to 4 million. And so regardless of the drawbacks, and I acknowledge your point that this is less than complete insurance, it is being offered and it is being sold.
Hi, I'm Don Levitt. I'm still that frustrated insurance agent.
Sounds like a job title.
It is. Well, I mean, it's sort of redundant too. But anyway, you had mentioned about the you favor high deductible plans, and so do I. And kind of piggybacking on what Ron was talking about, insurance agents are not too excited about selling real high deductible plans, and neither are insurance companies. If you were to have a deductible of $25,000, you could lower your premium by 60%, 50 to 60%. If you had a deductible of $50,000, you could lower it by 60 to 70%. Then the only question would be, how do you fund the underlying plan? Have you given any thought to how that might be done?
When you say how do you fund the underlying plan, I'm not picking up on that.
Well, I'm talking of having two plans, having one, a catastrophic plan that would cover, say, from 25 or 50,000 on up, and then a secondary plan that would cover the gap.
I don't think that'd be a good idea. Because coordination of those two benefits would be virtually impossible, and we'd run into the same kind of situation we have in Medicare, where one of the coverages is causing moral hazard or increased demand for the other coverage.
Okay,
in terms of insurance agents' unwillingness or lack of interest in selling these, I think I'll just make your job title even more complicated. In the future, I think the role of insurance agents is probably going to be smaller than it is now, because the means of purchasing this type of policy is being moved away from the traditional setting where individuals bought health insurance, that is by visiting an agent and maybe buying this along with auto and property insurance, to being an internet-based market.
Well, thanks very much, Roger.
Thank you.
I'd also like to compliment our audience on some very thought-provoking questions. It greatly appreciates and elevates the level of discussion.